Hello, everyone. Welcome to today's presentation. First, I'd like to introduce Susan to do a little introduction.
Hi, everybody. Good afternoon. Thanks for joining us today. Health First is very pleased to present the first of two webinars on risk-adjusted diagnosis coding. Today's focus is primary care, although specialists are welcome to attend as well. And we are very fortunate today to have Betsy Nicoletti back to present to us. Betsy has a wealth of knowledge and experience in the coding and compliance world. And she's known for expertise in simplifying complex coding for medical practices in her writing, speaking, and consulting gigs. She started codingintel.com, which is a coding library to keep groups up to date and accurate, resulting in decreased coding risk and revenue enhancement. Betsy is also the author of 2 books on coding published by Green Branch Publishing. I'll now turn it over to Betsy. Thank you.
Thank you so much, Susan. The first thing I'd like to do is go back in time. It was 1988, and I was filling in at the front desk of a general surgeon's office. And he would go off to the hospital. And when he came back, he'd bring a little card. And on that card, he'd write what he had done and the diagnosis code. And I said to him, Dr. Fabricant, this is in Springfield, Vermont, Dr. Fabricant, you know we get paid the same amount if you put 1 diagnosis on the claim form or 4, because he would write gallbladder disease, hypertension, hyperlipidemia, diabetes, and I was a lazy diagnosis coder, and I didn't want to code all those extra conditions. And he said to me, Betsy, I want the insurance company to know just how sick this patient is. So Dr. Fabricant, I'd like to say he was ahead of his time. Let me start out by saying that there are 2 handouts. There's a very wordy handout, which we're not going to read every word of that, but which I hope will be helpful for you as a resource. And then, of course, there's the PDF of the presentation itself, of the PowerPoint. And the reason I do the word handout, the print gets so small on the PowerPoint. You young people can read it, but some of us say, what? Where's my magnifying glass? We're going to do questions and answers at the end. And if you notice if you hover your mouse either at the top of the screen or the bottom of the screen, depending on your software, you're going to see you have Q&A. And so you can put a question in there. And if you have questions later, you will be able to I will read them later and answer them. There's also a chat. Use the chat if you're having trouble seeing or hearing, and Tammy will try to help you. Put your questions in, and we'll do those at the end. Also, there is 1 AAPC CEU credit, and the AAPC requires that you're on for the full hour in order to get that certificate. All right. So let's get started. How are physician services paid? Physician services are paid based on the fee schedule associated with the CPT code or the HCPC codes. And then, of course, there are modifiers. And I always joke, how does the payer use the diagnosis code? To deny the claim. But no, not really. Sometimes the diagnosis code brings us a denial, but of course the diagnosis code establishes the medical necessity for the service. It tells the payer why we did what we did. That's fee-for-service medicine, which we are all familiar with. Individual claims paid based on the fee schedule related to the code. Now, many of us are entering into contracts with risk adjustment. Contracts were going to be part of an accountable care organization, also known as a Medicare shared savings plan, or we might have contracts with our private payers that adjust our payment at the end of a contract year. So we still get paid the same amount on the individual claim, but at the end of a contract year, the payer will say, all right, how much did this population of patients cost to take care of? What were the quality metrics? Maybe patient satisfaction, and how sick were these patients? So those of you who were like me back in 1988, lazy diagnosis coders, I'm sure there are none of those on the call. Those of you who only put a single diagnosis on the claim form might have an adjustment at the end of the contract year that was slightly lower, where those of you who are more careful paint a complete picture of the patient's disease burden for the payer. And how do we paint a complete picture of the patient's disease burden for the payer? By the diagnosis codes we put on the claim form, of course. You might get a slight increase. So our payment stays the same for individual claims, but we will have we may, if we have risk-based diagnosis, an adjustment to payment at the end of a contract year. So this system was developed by Medicare, the one I'm going to talk about, HCCs, hierarchical condition categories. It was developed by Medicare to estimate future costs. So Medicare, for their Medicare Advantage plans, used to just pay the set fee per member. So if I'm a Medicare Advantage plan, Medicare pays me the same amount every month, this is in the past, for each Medicare beneficiary. And then they said, we should try to pay the Medicare Advantage plan a certain amount for healthy patients, and if the patients are sick, if they have a high disease burden, we'll pay them more. That's why when we're on the physician office, sometimes our Medicare Advantage plans come to us and say, we want to know all the diagnosis codes these patients have. So that's the system that we're using. It wasn't initially intended for physician payment use. It was to predict future costs. But now some of our contracts have these year-end adjustments. When you look at what codes have a risk-adjusted score, your physicians may not always agree with every single one of them, but that's the system that we're using. So what is risk adjustment? It refers to this being able to predict how sick our population of patients are. And how we're using it now in an accountable care organization is we are using diagnosis coding, which will have a risk adjusted factor, some diagnosis codes. We're using diagnosis coding to paint an accurate picture to the patient about how sick this patient is. Remember, Dr. Fabricant said to me, I want the payer to know just how sick this patient is. Of course, the bubble over my head in 1988 was, they don't care, they're going to pay us the same amount. But now, of course, they do care. So how is a risk-adjusted score calculated? First, a risk-adjusted score goes with the patient. So each individual patient has a risk adjustment score. And then if you have a panel of patients, all those patients together, we just average out the score for your panel of patients. And that patient is attributed to you in some way. So assigned to you or gets most of their care from you. That's how we can tell whether the patient is one of your patients or not. Typically, it's by claims. So it's calculated based on some demographic factors. So when I think about risk adjustment and HCCs, I think of two D words: demographics, diagnosis. So the first piece of risk adjustment is completely out of our control. The age and gender of the patient. Is the patient living at home or in an institution? Are they an end-stage renal disease patient? Are they dually eligible for Medicare and Medicaid? Some risk scores may include prescription drug data. HCCs do not. And here's the one that we can control, the last bullet on the slide. Diagnosis risk adjustment is based on the claims submitted in a contract year or a calendar year from an inpatient stay, an outpatient hospital stay, physician claims, or other healthcare professionals, so social workers, physical therapy. The diagnosis codes that are submitted on lab or x-ray reports, those are not used in this risk adjustment. So a patient has a risk-adjusted score. It's based partially on demographics, which we have no control over, and partially on the diagnosis codes that are submitted. Now, before I go further, let me just say that HCCs were developed by Medicare, again, for Medicare Advantage. Some of you may have contracts where a different proprietary system is used. So, for example, the Johns Hopkins risk score. They don't publish that, so I don't have access to it, but it often will include conditions that are more relevant for pediatrics and women's health. So what should we do? First, we're going to quickly follow ICD-10 guidelines. We're going to use the diagnosis code that describes the patient's diagnosis, symptom, complaint, condition, or problem. We're going to use the code that is chiefly responsible for the service we provided. We're going to assign the code to the highest level of specificity. Well, geez, why'd they give us so many codes if they wanted us to be specific? But seriously, you want to make sure that for chronic conditions or acute serious conditions that your physician, nurse practitioner, physician's assistant is treating, you want to be as specific as possible. There may be times when you are not treating the condition and you can't be specific. And in that, so I shouldn't have looked at chat, but I looked at chat, and Susan is telling us that OneCare uses Johns Hopkins risk scoring. That is good for you for pediatrics and women's health in particular, because as I look at the risk scores, and you'll see this when we look at the examples, sometimes because it was a Medicare Advantage plan, it is HCCs it's weighted towards adult problems. But the principles are the same. We're going to follow ICD-10 guidelines, and then I'm going to give you some other principles that we're definitely going to pay attention to. We don't code suspected, possible, probable. We know that. We code the symptom. We code a chronic condition as often as treated. And we code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. So this is the guideline we want to keep in mind when we're thinking about risk-adjusted scoring. Code the documented conditions that you're managing that require or affect require care, or that affect the care that you're doing. And we're going to see some examples of that. And then don't code conditions which no longer exist. That sounds so obvious, but neoplasms is the key one that we see the error in. I'm sure if we were together, you would be shaking your heads and agreeing with me. ICD-10 guidelines say, report the cancer diagnosis if the patient has evidence of cancer or is still receiving care. Otherwise, we move to personal history of. And then the leukemia codes are defined as in remission or in relapse. So we're going to come back to this issue of compliance again later. So what do you put on the claim form? What if the patient's condition is listed in the problem list, described in the past medical history, but the clinician doesn't describe it, doesn't say anything about it today? So we don't take those diagnoses from past medical history and put them all on the claim form. We don't say, well, now that we have risk-adjusted coding, we're going to make sure that we code every single thing that this patient has ever had. We follow that ICD-10 guideline, which visits that require or affect patient care or treatment on the day that we're seeing them. And where might we see that? So we might see that described in the HPI. We might see diagnostic tests reviewed or discussed in the clinical summary. So those are the claims, that the conditions that we're going to put on the claim form. If there are physicians, nurse practitioners, and PAs in the audience, all this talk about claim form, typically in an electronic health record, the problems that are selected in the assessment and the plan are the ones that are transferred to the claim form. So if you don't select it in your EMR, and of course you've got to check with your staff and make sure about how your EMR works, but if you don't select it in the assessment, it never gets reported on the claim form, so the payer doesn't know that they have it. The payer has a short memory and annually wipes clean all of the conditions that we report. So these conditions need to be reported to the payer every single year. And there are some status codes. I mean, HIV status is one. The patient has a positive HIV status. It doesn't get to be negative next year, but you still need to report it every single year. Some of you may have a software program in addition to your practice management system where it shows you risk-adjusted scores. It has an H next to it, and it'll show you whether you've reported it in the last year or not. But even without that, we're going to keep to these principles. Report the conditions annually. For chronic conditions that have a manifestation or a complication, then we definitely want to report that. So if it's a condition with hemorrhage, with ulceration, with spasm, and that describes your patient, you definitely want to report those. There are some chronic conditions where even the unspecified code has a risk-adjusted factor, but there are some that don't, or where the unspecified code has a lower risk-adjusted factor. So avoid unspecified codes for chronic conditions that you're treating, and then add status codes. We'll talk about which ones risk adjust, only a few do. We coders sometimes go mad with the Z codes. There are a lot of them, but only a few of them actually carry a risk adjusted score. So what are you going to do? You're going to make sure that for chronic conditions, acute conditions as well, but acute conditions, if they're serious, they're often in the hospital, and the hospital coders are doing this. But for patients who you're treating in the office for chronic conditions, report them annually. If there's a manifestation or a complication and a code that describes that, use that, and then add the status codes that matter. So what are we going to report on the claim form? We are going to report on the claim form conditions that the clinician has addressed today. We're going to remember that guideline of reporting conditions that coexist at the time of the visit that require or affect patient care or treatment. And sometimes this is discussed in the HPI. Sometimes the provider has looked at labs or diagnostic results. Most frequently, it's in the assessment and the plan. And sometimes the second condition is described as a comment under the first condition. We're still allowed to use that if somebody picks that up. Sometimes the clinician actually selects both codes. So here are just some examples. At a primary care visit, a patient comes in and their blood pressure is elevated, and the clinician wants to change their blood pressure medication. They also have chronic kidney disease, which the clinician isn't treating today, but which affects the care of the hypertension. So following ICD-10 guidelines, if it says one, hypertension, adjusting the medication, can't use this class of drugs or using this class of drugs because of the patient's chronic kidney disease, then following ICD-10 guidelines, we would put both of those on the claim form, the hypertension and the chronic kidney disease. We have another second example. You have an urgent care visit where the provider selects treatment, is treating a terrible case of poison ivy. And up in the HPI, it says the last time she took prednisone, her blood sugars went up to 350. So so that might be in the HPI. And then when we get to the assessment, number one, poison ivy. And if the physician or nurse practitioner PA says we're not giving prednisone because of her diabetes, then that affects the treatment of the poison ivy. We put both those conditions on the claim form. And sometimes at an annual exam, if the clinician has reviewed the patient's chronic problems, reviewed labs, renewed prescriptions, recommended treatment, then we would use those codes on the claim form. Now, what codes don't risk adjust? Some unspecified or uncomplicated codes for chronic conditions. So I want you to be as specific as possible for these serious long-term chronic conditions. Chest pain, muscle pain, signs and symptoms. There are hardly any codes in the chapter that starts with the letter R that carry a risk adjustment score. Conditions that may or may not be treated, like osteoarthritis. And then transitory and definitely treated conditions. For example, a patient with appendicitis, that doesn't change their risk score for next year because it's already been treated. So let me tell you how HCCs work. I said it was demographics and diagnoses, and there we are. So if I were a Medicare Advantage plan, the patient's demographic score, 80-year-old living in an institution, has a certain score, plus their diagnosis code scores would give me their risk factor, and then CMS would pay me a capitation rate, the same capitation rate for everybody based on the risk score. So how these are worked, and we'll see some examples of these. So this theoretical piece becomes more understandable when we get to the examples. Diagnosis codes are sorted into diagnosis groups, like codes together. The groups are sorted into condition categories and given a risk-adjusted factor, and we'll see some examples of that. And now, if you have printed out the Word handout, you might want to open that up just because the font's bigger there, but if you haven't, don't worry, I've got the examples in the PowerPoint slides. So certain diagnosis codes are assigned a weight, an HCC weight, or risk-adjusted factor. So how serious that condition is. If they're related conditions, they're in the same category, only the most serious one is counted, and we'll see an example of that. If there's a higher ranked condition, it causes in the same category as a lower ranked ones, the second one is ignored. And unrelated conditions are both counted, are additive. So when I'm thinking about diagnosis coding and HCCs, I want to go where the volume is. I always, wherever I'm giving this, I look up and see in their state what percentage of patients have diabetes. And Vermont is one of the lowest incidence of diabetes. So we should be proud. It seems like we see a lot of patients with diabetes. Even though I moved to Massachusetts, I still think of myself as a Vermonter. So 8% of Vermonters have diabetes, 27% are obese. In the population, 15% of us are depressed, and coronary artery disease causes 30% of deaths in patients over 35. So here, we're not going for the zebra, we're going for the horses. We're going to pay particular attention to the codes to the conditions that we treat most frequently. That's going to make the biggest difference. All right. So if you've opened up the Word handout, I've moved on to the top of page 10. So here's an example where two conditions in the same group are counted only once. So here's a patient with type 2 diabetes with two different complications. Remember I said if a patient has a chronic condition and the word with is in it, we want to make sure we're using that condition if that describes the patient's condition. If the patient had 5 complications of diabetes, it still only counts once. So here we've got type 2 diabetes, we've got the code for it, E11.21. It's in group 18, and the risk-adjusted factor, or the HCC weight, assigned to group 18 is 0.368. But no matter how many conditions that patient has in group 18, and all of the chronic conditions with complications are in there, it only counts once. Now, if I'm giving this to presentation to a lot of physicians, they say, well, should we only put one of them down? And I say, well, we're going to put down the ones that make sense. If you're treating 3 of them and you have comments about all 3 of them, we're going to put all 3 of them down, but it counts once. So type 2 diabetes without complications has a risk score of 0.104, with chronic or acute complications 0.318, long-term use of insulin 0.104, and then I just have a type 2 diabetes with nephropathy code there at the bottom of the page. We're going to see an example of how long-term use of insulin almost never adds anything, because you're only going to count either the type 2 diabetes without complications or the type 2 diabetes with long-term use of the long-term use of insulin. But we'll see an example of that. Here's a patient who, when you look at the past medical history, it says that the patient has type 2 diabetes, they have peripheral vascular disease. As a coder, I don't know if their circulatory complications are related to the peripheral vascular disease, but the clinician does. And the past medical history says that the patient has an acquired absence of the toe or digit. So a Z code for a non-traumatic amputation. Now, I'm going to go 2 slides ahead because I've got the next one a little bit out of order. So if all I coded was type 2 diabetes uncomplicated, I would have an E11.9. I have a low risk score for that. But if the physician or nurse practitioner or PA in the assessment in the plan noted that it was other circulatory complications, I get the higher weight. The long-term use of insulin doesn't count because I have a higher weighted code that's related. So the type 2 diabetes is higher rated, it's got a higher weight, and so it actually adding that Z code for long-term use of insulin doesn't get us a higher score. I'm not saying we don't report it, because that might be something important in terms of quality scores and where we want to be able to pull data out. I'm just telling you it doesn't add to the score. Peripheral vascular disease adds, and then this acquired absence of the left great toe. Now you say to yourself, I reported that in December of 2017. Surely I don't have to report it again in 2018. But remember, the payer has a short memory. You must report all the conditions every calendar year if you want them to count it. So here's one where if the clinician had described this in the assessment in the plan, we would report all of these codes and our risk score would be much higher than if we had just used type 2 diabetes uncomplicated or type 2 diabetes with circulatory complications. And remember, our goal here is not just to get the highest risk score ever, just like our goal isn't to get the highest level of E&M code. Our goal in this diagnosis coding is to provide the payer with an accurate description of the disease burden that our patients have, because that disease burden explains utilization, outcome, and quality codes. All right, I'm going back one. Here you have a patient who's got chronic kidney disease, stage 5, and type 2 diabetes with diabetic nephropathy and a high BMI, and we're going to talk about BMI. If the clinician doesn't relate the diabetic nephropathy to the chronic kidney disease, and we just used E11.9, again, we would have a lower risk score. And I, as a coder, am not going to say, oh, those must be related. I'm going to choose E11.21. We count on our clinicians to document the relationships for the complications and the manifestations. Now, in an EMR, often they have selected the combination code, type 2 diabetes with diabetic nephropathy. So if they've selected that, that's them telling us these 2 things are related. So here, accurately coding all of those conditions adds to the risk score that that patient has. Now, often I see these 3 things commonly reported: hypertension, hyperlipidemia, and diabetes without complications. The only one of those that carries a risk-adjusted score is diabetes without complications, and that is 1.04. 0.104, sorry, 0.104. If, however, we use diabetes with specified complications, and that means lipids, that's the specified complications we're talking about, then we get a risk score, our risk score triples to 0.318. So when we're thinking about diabetes, we want to always be using the codes with if that describes what the patient has. Here's another example that came from a patient's chart. Patient with diabetes and neuropathy, and the clinician selected E11.9 and G62.9, neuropathy unspecified. Did I say nephropathy or neuropathy? I've got my R's in the wrong place there. So that's what the clinician chose, these first two codes on the slide, E11.9 and G62.9. However, and again, if I'm the coder, I'm not going to say, oh, those must be related. If the clinician relates them, or the clinician chooses E11.42, type 2 diabetes with polyneuropathy, then that triples the risk score. So if I were just wondering if I had any of this, if I had an EMR that allowed me to look and see if I've reported these first two codes on this slide on any one patient, then you could ask your clinician, are these related? And when the patient comes in next time, would you please update their problem list? So we're almost done with diabetes here. We're going to use E11.65, type 2 diabetes with hyperglycemia if a patient has a hemoglobin A1C of greater than 7. We have one for hypoglycemia when they've had a blood sugar of less than 70. And patients with polyneuropathy, we're going to use the E11.42. All right, so because diabetes is seen so frequently, we want to make sure that we are accurately reporting it. Obesity and high BMI. So patients who have a BMI of 40 or greater, you can use either the BMI code, the specific Z BMI code, or E66.01, morbid obesity. It's another example of where it doesn't count twice. They're both in the same group. They have the same weight. So whether you used it, whether you used it once or twice, it wouldn't matter. They don't add together. However, it is permissible to use the code for morbid obesity for patients who have a BMI of 35 or greater, 35 to 39.9, if the patient has two comorbid conditions and the clinician, here again, it's up to the clinician, and the clinician notes that those chronic diseases are affected by the obesity. I told her her weight was contributing to her coronary artery disease and hypertension. Then you could use E66.01 for that patient. There are a list of cardiovascular conditions. This is an example of when even some unspecified codes carry the same weight. But there are many cardiac codes where a with manifestation carries a higher weight. So angina with spasm, varicose veins with ulcer. If you can find, if that condition describes your patient, then you want to make sure you're using the more specific code. For atherosclerosis, codes are specific by site. You all know that if you're doing the coding. Sites below the neck risk adjust, and manifestations like claudication or ulcer carry a higher score. So you want to be as accurate about those as you possibly can. Let's say you have a patient who's coming in for Coumadin clinic. There are some Z codes which we would use, which have no HCC weight at all. So long-term use of anticoagulants or personal history of a PE, neither of those have a risk-adjusted score. Whereas if you have a patient who has a chronic PE, and some clinicians say, what? I'm just telling you what the code is, or a patient with chronic AFib, and you report that once in the contract year. So if you were running a Coumadin clinic, you wouldn't have to report the underlying medical condition every single time. But at some point during the course of the year, if the patient has chronic AFib, you want to make sure that you're reporting it, because that carries the score, whereas the long-term use of anticoagulants doesn't. Of course, we're only reporting it when our clinicians are helping us with the documentation. All the codes in heart failure have the same risk-adjusted score. And this is unlike what happens in the hospital, where different types of heart failure contribute to a different DRG. In the HCC world, all the types do. And all conditions in category code J44 for COPD carry the same risk-adjusted score. Sometimes we have problems with our problem lists and our assessment and plans. And if time were unlimited, then our clinicians could update the problem lists to the most specific codes. But this clearly is something that takes a lot of time and that slows clinicians down. Anything we can do to help is good, but if when the patient's echo results come into the office, we update the problem list to the more specific type of CHF, then it's done. And we don't have to do it again. You don't have to go back and relook that up. But I know that there's often just not enough time in the day for those things. Now, I'd like to spend a little bit of time talking about depression, and I hope you're not all depressed by the time I'm done. If you do have the handout on page 15, I've listed all the depression codes in category F32 and F33. You know, when we moved from ICD-9 to ICD-10, I was delighted that there were going to be mapping programs. Oh gosh, I said, this is swell. Little did I know, I should have known, smarter people than I predicted this and knew this. All the problems we had in ICD-9, when we mapped those over to ICD-10, became bigger problems because we had so many more codes that sometimes, even if it was specific in ICD-9, it could only map to an unspecified code in ICD-10. And depression is the prime example. It's the poster child for problems with mapping. In most of your EMRs, when you type in the words depression, primary depression, mood disorder, the blues, sadness, many of those terms, what comes up is F32.9. And it could be defined in all those different ways. But here's the real definition of F32.9. Major depressive disorder, single episode, unspecified. And it carries no HCC weight. It's not in a category. It doesn't risk adjust. So all those patients who we've been seeing in primary care for 5 years, 8 years, and they've been on an antidepressant all that time, if the code we're using is F32.9, it does not carry a risk adjusted score. There are 3 codes in this series: F32.81, premenstrual dysphoric disorder, F32.89, other specified depressive episodes, and F32.9, major depressive disorder, single episode, unspecified, that don't risk adjust. All of the other codes in the F32 category do: major depressive disorder, single episode, mild, moderate, severe, in full or part remission. And all of the codes in F33, major depressive disorder, recurrent, even the unspecified code, risks adjust. So if we could do only one thing in primary care, well, more than one thing, we're going to make sure our diabetes coding is very specific. Depression is even a higher incidence, and who's treating depression in this country? There aren't enough psychiatrists. It's primary care. If you can update this, that's very helpful. And the depression codes are defined by DSM-5. These are psychiatric definitions. If anybody needs the description of what's a major depression, I will send that to Susan straight from the DSM-5 book so that you can show it to your clinicians. So we want to get rid of from our problem lists as much as possible F32.9. When I get a frequency report from primary care, depression is often the 5th or 6th most frequently used code, F32.9. We want to move that down the line and have more specific depression codes. Substance abuse, some of the substance use and abuse codes that are uncomplicated and unspecified don't carry a risk-adjusted score, whereas the dependence codes typically do carry a risk-adjusted score. F11.20, opioid dependence, uncomplicated, does risk adjust. So if we remember when we first learned ICD-10, the substance abuse codes are divided into use, abuse, and dependence is considered the most serious. So even dependence unspecified, some of those codes risk adjust, and then many that have a with, with other complications, those codes will risk adjust. Sometimes our clinicians don't want to use these codes because the patient goes into the portal or gets their clinical summary and they see that they've been accused of having alcohol abuse. I don't know what to say about that. That's between the doctor and the patient, of course, but some of these codes do carry a risk-adjusted factor. And then I have obesity if you're on the handout on page 16. On page 17, I've got some infectious diseases. I've put them up here on the screen, but again, the print is small, so they're also on the page. Let's talk about the difference between HIV, B20, and asymptomatic human immunodeficiency virus, infection status, Z21. See that they're in the same category and carry the same weight. So sometimes I hear from infectious disease clinicians that they don't want to use asymptomatic HIV because the payer won't know how sick the patient is, and they really want to use B20. If I'm following ICD-10 rules, I only use B20 if the patient has a manifestation of AIDS or has been treated for a manifestation in the past, even if they don't currently have one. But either one carries the same risk-adjusted score. And then all the viral hepatitis have a risk-adjusted score. Pneumonia, the garden variety pneumonia that we see in the office, the J18.9, that does not risk adjust. The pneumonia codes that risk adjust are the ones the patient would be in the hospital for, because we wouldn't know. Gram-positive pneumonia, gram-negative pneumonia, those are hospitalized patients. Now let's talk for a minute about compliance, because I said, I started this at the very beginning, I talked about neoplasm. Stroke is another one of those conditions where the clinician sees a patient who has had a stroke, maybe last month, last week, they were in the hospital for it, and they search in the EMR for stroke, and up comes I-63. We don't want to use I-63. I-63 is for when the patient is currently having a stroke. That's what would have been submitted from the hospital claim. When the patient returns to see us, we're going to use either something from the I-69 code, a sequela of the stroke, if the patient has a sequela, or personal history of TIA and cerebral infarction. I-63 carries a risk-adjusted factor, a weight. Some of the I-69 codes, if the after effect is hemiparesis, that carries a risk-adjusted score. This Z86.73 does not, but if the patient doesn't have any after effects, that's the code we're going to use. Same thing for TIA, although in this case, G45 doesn't risk adjust either, but we wouldn't use TIA for a patient who isn't currently having symptoms. We use personal history of. In terms of neoplasm, here's one where if we could, if we had the time, we would fix our problem lists. Because if a patient has a history of prostate cancer and is still getting surveillance visits every year or more frequently, every quarter, but they aren't currently receiving treatment and they have no evidence of the disease, we don't pick the neoplasm code. We pick personal history of. And sometimes physicians don't want to do that. They say, oh, it doesn't pay. The payer won't pay me for surveillance visits. I don't think that's true. When I ask coders who work in surgical practices, do you get paid for that personal history of breast cancer or colon cancer? They tell me yes. But from a compliance and risk point of view, the neoplasm codes have risk adjusted scores, whereas personal history doesn't. So now that we're trying to present this accurate picture to our payer, and where our revenue in future years might depend on our risk score, we want to make sure that we are very compliant about our cancer diagnosis codes. And then patients seen in the office for follow-up after an MI, we use the MI code for 28 days, and then we go to old MI. However, if the patient has coronary artery disease of some type, we're going to use that as well. Now, status codes, there are not many status codes that risk adjust. There are a full list of them in the guide on pages 22 and 23. There are so few of them that I could put them all on 2 pages in this guide, even though we coders have never seen a Z code we didn't love, right? So the codes that risk adjust, HIV status that we talked about, encounter for or the status of an artificial opening. So if you have a patient who has a colostomy or a tracheostomy, even if you aren't the treating physician, there are 2 sets of those codes. One is encounter for treating it, and the other is that the patient has the status of that. So you want to make sure that if it's a chronic long-term issue, that that you're reporting that once in a contract year. BMI of over 40 or a BMI of over 35 with 2 chronic conditions. Long-term use of insulin, we're going to report it, even though in the medical, in the HCC world, it often doesn't get counted because we've got the diabetes codes. Acquired absence of toe or foot, make sure that you're reporting that. And then organ transplant status. So again, I want us to pay the most attention to the conditions that we see most frequently. So if you run your ICD-10 frequency report, that's going to be diabetes. Make sure if you have a patient with diabetes and hyperlipidemia, you're moving to that code, type 2 diabetes with other specified complications, depression, obesity, heart disease, sometimes some of these infectious diseases. But pay attention to the things you report most frequently. Quadriplegia and paraplegia aren't status codes, of course. They're in the nervous system chapter. Those risk adjust. And then monoplegia and hemiplegia, which are late effects of strokes. Again, not Z codes, that I-69 codes, that risks adjust as well. So on page 20, so when I was doing this early on, I asked for a list of the most frequently reported ICD-10 codes. And there were a lot of codes that don't risk adjust. So if you do have the handout and look on page 20, I've put some of those down. Anxiety disorder is one that does not risk adjust. Asthma in the HCC model does not. We hope it does in the Johns Hopkins model. The Johns Hopkins model was developed for the broader range of our population of patients, not just Medicare patients. So anyways, I've got just that list on those pages of conditions that don't risk adjust. By the way, we have about 10 minutes left. If you have a question, go up and write it in the Q&A section, and I will make sure and answer those before we're done. On page 21, if you have it open, let me just talk. So when I looked at this, I said, well, what kind of things risk adjust in each chapter? And there are some conditions, hardly anything in the ear system, organ system diagnosis codes. Nothing, hardly anything in the eye chapter, some, but not many. Things that risk adjust, so I put some examples down. Serious infectious diseases, of course, neoplasms that we talked about, and then some diseases of the blood, lymphoma, melanoma, sickle cell, not garden variety of anemia, but more serious and specific types of anemia to carry a risk adjusted score. The endocrine disorders we talked about, the obesity and diabetes, major depressive disorder we mentioned, substance abuse, and then schizophrenia and bipolar disorder. All of the codes in bipolar disease carry a risk adjusted score, even the unspecified one. And I know in primary care, we try not to be the clinician that is prescribing the medications, but often are. But if it affects the treatment of your patient, we follow that ICD-10 rule and report bipolar disorder. Diseases of the nervous system, Parkinson's disease. We had a list of diseases of the circulatory system in the cardiovascular chapter. Here, my voice is given out on me after almost less than an hour. Diseases of the respiratory, COPD we see pretty frequently. Acute or chronic respiratory failure is going to be in the hospital anyways. And then for pneumonia, when we know the organism. In the digestive system chapter, Crohn's, ulcerative colitis, and those codes, if we're the surgeon, then we know whether it's the large or the small intestine with or without hemorrhage, or both. Often for patients with Crohn's disease that we're seeing in primary care, we don't know. But for Crohn's disease, even the unspecified code carries a risk-adjusted score. And then cirrhosis and, of course, acute ulcer. Anything that's acute, I haven't focused on, because if it's acute, the patient's going to be in the hospital. Presumably it's time limited, and we're going to get that reported there. Only stage 4 pressure and non-pressure ulcers and higher. In the musculoskeletal system, the things that we would most commonly see would be a patient with a age-related osteoarthritis with a pathological fracture, with a current fracture. Those codes risk adjust. And as I mentioned, if we're in the signs and symptoms chapter, almost nothing risk adjusts. And then, of course, severe trauma. What we want to do is focus on conditions that we see most frequently. So we want all of our codes to be specific, but in particular, we're going to be specific about the conditions that we are treating. We want to make sure that we're following ICD-10 guidelines, of course, and we're going to code documented conditions which coexist at the time of the visit that require or affect patient care. And we're going to find that either in the HPI or in the assessment in the plan, typically. We might sometimes see, oh, they're managing things because of the labs, but they would be discussed in the assessment in the plan. We're not going to make assumptions, and we're not going to go up into the past medical history or the problem list in order to select codes. If a chronic condition has a manifestation or a complication, if the word with is in it and that describes the patient, we want to make sure that we are reporting that. And we're going to report these annually, even the status codes, even though it hasn't changed, because we remember that the payer has a short memory. So we don't seem to have any questions. I don't know if that's a good or a bad sign, but I'm going to turn this back over to Susan. I very much appreciate that Vermont Health First has asked me to do this, and if there are questions that come up later, please send them to Susan and she can pass those on to me. Susan, do you want to say a few words?
Well, I wonder if we should open up the phone line and see if anyone chimes in.
All right. So there is a thing where you can raise your hand. So if anybody wanted to do that and raise their hand, then I would unmute your line. Oops. And and call on you. Or if you want to type in a question. And we'll wait a few minutes here.
Yeah.
You know, this, go ahead.
Go ahead. I was just going to say, in the meantime, just to let everybody know, this webinar is being recorded, and we will put it on the Health First YouTube page, and we'll circulate a link to everyone once it is available. And we do hope you found this helpful.
So Susan, it does not look like we're going to have questions here, but if someone sends you some later, please feel free to forward those to me. And thank you very much.
No, thank you very much. Bye-bye, everybody.
Bye-bye.